going to demonstrate how to use the Philips defibrillator monitor. So to do this, I'm first going to turn it onto the monitor and run operational check. So I'm going to menu down to other, operational check, run operational check, acknowledge. So while it's doing that, I'm just going to get ready. So it's going to want to run a test shock. So to do this, I'm going to attach the test block, turn it up to 150 joules, and it's going to tell me when to run the shock. Cool. And so I'm going to press charge, and then I'm going to press shock.
Shock delivered.
So I heard it say shock delivered, so I'm going to say yes, I heard it. So while it's running the check, I'm just going to go through the other components of the defibrillator. So in this right pocket, we have the 3-lead. So the 3-lead attaches to the torso of the patient. So this black cord attaches to the left arm by the shoulder. This white one attaches to the right arm by the shoulder. And this red one attaches above the left leg, just above the hip. So this pocket also has the SpO2 monitor, which you just pop on the patient's finger like so. We also have the EtCO2 monitor, which just pops onto the ventilation tube if they need it. We also have the BP cuff, which is not in there, but this is it. There's usually 2 to 3 sizes, child, adult, and light adult. In this side we have the 12-lead and these defib cords, which usually have pads on them, but because we have a mannequin, not today. And in the back we have aspirin, a razor, a spare battery, and what am I missing? And spare paper. So I'm just going to wait for it to finish running its test. Cool, so it's finished its operational check. So I'm just going to print it. It says that it's passed. So I can just print it out to check that it has done it. It's passed. So I'm just going to stop it there by pressing that little white button. And so I can see that it has passed on here as well. So we can also run, I'm going to exit the operational check, and we can run a test shock. So I'm just going to take off the test block and pop that back in there. And then I'm going to attach the defibrillator cords and pop these on my patient. So one just goes on the right, like so. So to do this, I'm going to leave it at 150 joules, and I'm just going to stay clear of the patient. I'm going to charge it so it gets up to 150. I'm going to press shock. So we can also, I'm just going to stop that. We can also cancel the shock, so we just charge it, and then once it reaches 150, I can press disarm, and it stops the shock from being delivered. So we can also change the, I'm going to leave it on there, actually. We can also change the heart rate volume, so we go down to volume, go down to QRS, and I'm going to turn it to loud. We can also change the ECG display, so go menu, displayed waves, wave 1, pads, and I'm going to leave it at 1. So we can also change the display of the waves, but because our patient is dead, it won't show up as any different today. So we can also turn it into AED mode. So in AED mode, it is automatic and it tells you how to conduct the shock. So I'm just going to turn it off. So on the back, we can also check the battery level and change the batteries. So you just press the buttons at the top to see how much charge they have. At this rate, one is full and one is not. So we can also change the batteries by squeezing each side, pulling it out, squeezing them back and pushing it back in. Cool. We can also change the printer paper. So to do this, you want to pull this out, push it up and pull it out. So this one doesn't actually need new paper, so I'll just put this one back in. So you want to pull it up, pull the little thing at the top up, pull it out, pop it back in, and and make sure that the red is facing towards the back of the defibrillator. So today I'm going to demonstrate how to use a suction unit. So firstly you want to turn it on to max, check that the battery lights light up, and then you want to test it by kinking the tubing and holding down the test button. It should light up to the max 500, but the suction doesn't actually work. You also want to check the catheter and test it, so you're going to put your thumb over the hole and then put it to your glove to feel if you can feel it sucking. You also want to check it for damage, the catheter and the tube, but this one seems to be okay. So when to use it is if the patient has foreign body or fluid in their mouth and they have a low GCS. But first you want to put them in the recovery position and try to get rid of most of that fluid that way. So when using it, you want to put it in only as far as you can see and then move it out in a circular motion for no more than 10 seconds. So complications of the suction unit is that it can cause hypoxia, laryngospasms, soft tissue damage and induce vomiting. You never want to use a rigid catheter in a moving vehicle or with seizing patients, only ever using a soft catheter. So today I'm going to demonstrate how to use an oxygen cylinder. So oxygen cylinders usually come in white or black, and they just say oxygen on the outside of the cylinder. We use regulators on them, and these help control the flow of oxygen out of the cylinder. So they have a little Bodak seal, and you want to make sure it is in good condition before putting it on. So when you put it on, you want to line up the two prongs and just tighten up the regulator. Cool. So once you've tightened it up, you just want to turn the oxygen on, and you can see on the monitor that there is plenty of oxygen in the cylinder. So you just want to check the flow rates. Okay, these got to 25. Yeah, so you can hear oxygen coming out at each one of them. So we would use oxygen in patients that have suffered from shock, respiratory distress, patients below 94% SpO2, carbon monoxide poisoning and smoke inhalation. You always want to leave it lying on the ground to ensure its safety. So today I'm going to demonstrate nasal prongs. Nasal prongs provide 20 to 40% oxygen at a flow rate between 2 and 4%. We usually typically use these in mild patients who don't need much oxygen. They're non-invasive, so to use them you want to attach the oxygen tubing to the cylinder, to the regulator, and then you want to make sure that the tank is on and turn it up to 2. So you're just going to insert them into the nostrils and put them behind the ears, and then you can tighten them up. This provides oxygen to the patient. Then when you remove them, you firstly remove them, then you turn off the flow rate, and then turn off the cylinder. So before we take the regulator off, we want to bleed it out. So make sure that the tank is off, and then just turn it up until you stop hearing oxygen coming out. Then you unscrew it, remove it, and that's how to use the O2 tank. So this is the response bag. I'm just going to run through it. So in the top pocket is the vitals pocket. So we have a stethoscope, shearers, BP cuff for adult and child. We have a BGL kit, thermometers with covers, and we have a alcohol swipes if we need them. And this bottom kit is the paramedic drug kit will be found in here. We work with a paramedic. We also have PPE, so we have gowns, glasses and face masks if we need them. This is the hemorrhage pocket for bleeding patients, so we have tourniquet, Verse bandages, medical tape and saline solution. So in this side we have the blood sugar management, so we have glucagon, glucose and hypergel if we need it. This one has some extra stuff in it, so it has some vomit bags, spinal lanyards and ethyl chloride if we need it. This main pocket is mainly airway management, so we have bag valve masks for adult and child. They include filters and PEEP valves if we need them. This is an IV kit for a paramedic. We have the advanced airway management, which we won't use, but ICPs will. It has LMAs in it and stuff like that. We have the towel which goes under the patient's neck. We have saline solution and tubing for those bags. We have a slippery SAM. We also have cardboard splints and cervical collars. In this top pocket we have methoxyflurane, we have Panadol, aspirin and ibuprofen. In this middle pocket we have rubbish bags, a laryngoscope, forceps, NPAs and OPAs. In this bottom we have advanced drugs such as adrenaline and salbutamol, and we have nasal prongs and oxygen tubing. So we've been dispatched to a 65-year-old male complaining of chest pain, and he has since collapsed. Upon entry of the scene, we're going to check for dangers and a possible exit in case anything goes wrong. George and I both have our gloves and our glasses on for correct PPE. We can now enter the scene. Hello sir, can you hear me? So no verbal response. I'm now going to check for a pain stimulus. No pain response. I'm just going to check his airway for any possible obstructions in the jaw thrust. Can't see any possible obstructions. I'm now going to listen to his breathing for 10 seconds using look, listen, and feel. No breathing. George, would you please start CPR? Yep. I don't hear any breathing. AUT to comms requesting R50 backup for cardiac arrest. When using the defibrillator, I'm going to try and work around George to minimise the time off the chest.
Analysing heart rhythm. Do not
Stay clear of
touch
the patient,
the
George.
Shock advised.
Stay clear.
Charging.
Everyone's clear.
Clear. Stay clear of patient.
Everyone's clear.
Deliver shock
Please
deliver.
start CPR, George.
Pause. Start CPR.
So I'm just going to put this towel under his head to maximise his airway using the sniffers position. So I'm going to use a bag valve mask. When using a bag valve mask, it delivers 100% oxygen at a flow rate of 15 litres per minute. We want to be careful for gastric inflation, hyperventilation, and barotrauma. So when using a bag valve mask, you want to use an OPA. So an OPA can be used if the person has, can't be used if the person has trismus, or if they have a gag reflex, you want to take it straight out. So when measuring OPA, you want to measure from the corner of the mouth down to the corner of the mandible. So you want to face it upwards to about halfway, then turn it 180 degrees and put the rest of the way down. So when using the bag valve mask, you want to use the C3 grip. You want to do it 30 to 2. So George, when you're ready, count up from 25 to 30, and then I'll deliver 2 breaths.
Cool. 5, 6, 27, 28, 29, 30.
Cool. So when we can also use an NPA. So an NPA can't be used if the person has facial trauma or possible traumatic brain injury, as it may go into the wrong cavity. So you want to measure it from the tip of the ears down to the tip of the mandible. You want to put a little bit of lube on it to help it slide down. You want to find the biggest nostril, insert it perpendicular, and if you find any obstructions, you just want to twist it and continue going down. So when you're ready, George, count from 25 to 30, please.
Cool. 25, 26, 27, 28, 29, 30.
Please continue CPR. So George is doing good CPR, about a third of the depth of the chest, to about 100 to 110 beats per minute.
Stop
We're
CPR.
going to swap over now to
Analysing
minimise
heart rhythm.
fatigue for both of us when
Stay
doing
clear
CPR.
of patient. Analysing heart rhythm. No shock advised. Pause. If needed, start CPR.
Would you please continue my counting for me, George?
Yep. 1, 2, 3.
So at this stage, I would ask for a medical history. So I would ask if anyone continued CPR before we got here, if anyone saw what happened, and what he was doing before he collapsed. I'd also
26,
ask
27, 28, 29, 30.
I'd also ask if he has any allergies or any medical history of cardiac, and if he takes any medication and how regularly does he take it.
24, 25, 26, 27, 29, 30.
So when doing breaths, you want to take your hands completely off the chest to allow the lungs to completely inflate with air. When doing CPR, you also want to make sure that you measure your hands from under the armpit to the middle of the chest.
25, 26, 27, 28, 29, 30.
So when doing breaths, you want to gently squeeze the bag to about a third of the depth and use the C3 grip.
25, 26, 27, 28, 29, 30.
We would continue to rotate until backup arrives to minimize fatigue for both of us.
25, 26, 27, 28, 29, 30.
So you can see good and equal chest rise from the breaths.
Stop CPR.